Welcome, everyone. My name is Melanie. I'm a nurse practitioner and I work with the Regional Palliative Consultation team here in the Ottawa area. So today I'm going to talk a little bit about emergencies that we may encounter in palliative care. So our objectives of today's presentation are to discuss the importance of recognizing palliative emergencies, becoming familiar with common presentations, and understand the available options and the impact of goals of care on the decision making around these events. And then just a list of some things that we typically see in palliative care that could be considered emergencies. I think delirium is quite a big one that we see frequently in the community setting. We also have seizures, respiratory distress, severe hemorrhaging, and hemorrhaging typically is seen from the GI tract, either upper or lower, and the respiratory system. We can see hypercalcemia, particularly in cases of cancers that have metastasized to the bone. We see bowel obstruction, spinal cord compression, pain crisis, and occasionally we will see SVC syndrome. So the potential goals in treating emergencies, especially in this palliative care population, saying palliative emergency is almost like an oxymoron, but the importance of recognizing the palliative emergencies is that in treating them and treating the underlying cause, if possible, of the emergency, we can improve function. We can make that patient more comfortable. We perhaps can prolong life or prevent a premature death from this emergency, improve quality of life, and it may lead to a less complicated bereavement for our family members. So in the case of palliative emergencies, emergent syndrome management, meaning treating the underlying cause, sometimes, right? Sometimes we can do that, but emergent symptom management will be an always for us. So we always want to have resources to manage what the patient is feeling, particularly in the case of distressing symptoms. So the first emergency, I've picked 3 to talk about today that can have sort of interesting presentations. So the first we'll talk about is a spinal cord compression. So in this picture, you can see the spinal cord running through. We have a tumor that's arising from the bone of the vertebrae that's compressing on the spinal cord. So the spinal cord compression is any condition that puts pressure on your spinal cord. It can occur anywhere between the neck and the lower back, and even into the sacral or coccyx region, which we call the cauda equina. It can be caused by tumors, infection, so a big pocket of pus pressing against that spinal cord, bruising, or other bone diseases. In the case of today's presentation, we'll be talking around SCC caused by tumors. So malignant spinal cord compression, or the spinal cord compression coming from that tumor, cancer, it is an emergency because if left untreated, it can lead to permanent neurologic impairments, which are a detriment to the patient's quality of life. So this is again another picture of our neurologic system and a distribution of where we see the most common spinal cord compressions. So commonly in this mid to upper back region. Next is that lower back region, the lumbar spine, and then we get some cervical ones as well. So in terms of your clinical presentation of a spinal cord compression, certainly we often are going to start by seeing pain. So the patient may describe pain in their back. They often can localize it to a region in their back. And for any of your patients that have a known cancer that has metastasized to bone, a new onset of pain in the back always warrants attention. We often will see weakness. So this would be in the legs, and sometimes depending on the level of the spine that's affected, weakness in the arms. Initially, this might present as patients saying, you know, it's really hard to get up out of bed in the morning, or it's hard to get out of my chair. They're feeling like their legs really aren't carrying them as well as they used to. Similarly, they might be having trouble opening jars, manipulating car keys, things like that. Later in the presentation, oh, sorry, we also may see falls, like a new onset of falls would be like something that might trigger your alarm system a little bit. Sensory dysfunction often comes a little bit later in the presentation. So this cord compression that's been hanging around for a little bit of time will lead to sensory dysfunction. Most primarily, we're seeing that in the saddle region. So if a patient was riding a horse, thinking about where the inside of their thighs would sit against a saddle, it's called saddle paresthesia. So what that is numbness in that saddle region. Sometimes we'll see reflexes go a little bonkers, numbness and tingling down the legs. And again, the next step in terms of late presentation would be autonomic dysfunction. And most notably, those alarm signs that we're looking for would be urinary retention. So if your patient, if you ask them when was the last time they had a good pee, and if they say, oh, geez, I haven't peed since yesterday morning, and you can assess them and see that their bladder is full, that would be a pretty big alarm sign that this patient needs some intervention. Similarly, these patients will also lose muscle control of their external sphincter, which manifests in fecal incontinence. So a new fecal incontinence because they're just not feeling the sensation to defecate. So in order of presentation, like initially these will present with pain, and in late presentation, we're looking at this urinary retention and fecal incontinence. So again, in terms of clinical signs, when we're looking at the local back pain, the patient will be able to point you to the direction. The pain will be present at activity and at rest. It's usually always in the midline, because if you think about the spine, of course, being in the center of the back, and that tumor taking up space and pressing on the spinal cord at the area where the tumor is. So in the spine, it's usually constant and close to where the lesion is. It can be relieved by sitting or standing up. And it's often exacerbated in cases where there's like a sudden increase in thoracic pressure. So coughing, sneezing, straining to have a bowel movement. It will often exacerbate that pain. We sometimes can see radicular pain with this, and that's more of this burning, tingling, numbness, that weakness. Again, this worsens with the movement, with coughing, sneezing, Valsalva. And the pain often wraps around the area or the dermatome of that region of the spine, so where that innervates. Patients will sometimes say it feels like they have a belt wrapped around their waist and somebody's squeezing it tight. So it's wraparound pain. And again, with the neurologic, we see that numbness and tingling in arms and legs. We see a change in their gait or the way they're walking. There's weakness in their limbs and the unexplained changes in bowel and bladder function. So the reason we consider this a palliative emergency is that as the compression gets worse and worse, we see a progression of symptoms. Initially, it may be very subtle with that back pain, but if we let it progress, it can become essentially a paraplegia. And it's really hard to reverse the damage once the damage is done. So a quicker intervention means we can spare a lot of loss of function. Okay, so if left untreated, the neurologic damage can occur, leading to paraplegia. We often see that once a patient progresses to a certain point, it's very poor prognostically, meaning shorter survival. In terms of diagnostic investigations, an MRI is the gold standard, and it would be the whole spine to identify presence of a lesion and then compression of the cord. In some cases, CT may be what's available to us, and sometimes these can be picked up on CT, but again, the MRI is going to be our gold standard. And treatment options. So if one of my nurses in the community were able to identify this and call me and say, I think this is what we're dealing with, sometimes what I'll do is look up and see if we have any known lesions at that area. But my first course of action always, until we get a plan in place, is to really crank up some steroids for them. So something like dexamethasone, which acts as a really potent anti-inflammatory. And the idea is we reduce swelling around that tumor, which can take pressure off the spinal cord. And it just buys us a little bit of time to come up with a good plan. We want to make sure that we're treating the pain, of course. And in order to treat the underlying cause, we really do need some acute care interventions, such as radiotherapy. So through the rapid radiation program at the Ottawa Hospital, we might look for something like systemic chemotherapy as an add-on that might decrease the tumor size and take away some pressure from that cord. In some cases, spinal surgery or decompression surgery may be an option. And then certainly post-radiation and post-surgery or post-intervention, looking at some rehabilitation. So, involvement of physiotherapy and occupational therapy, specialized equipment to hopefully get some function back for these patients. So in terms of prognosis, unfortunately, developing a spinal cord compression usually isn't a great sign prognostically. It often indicates, or it's often a sign that the patient's cancer has progressed. So whether it was in a primary organ and now has spread to the bone, that would represent metastases. Prognosis is also dependent on the extent of symptoms coming from that spinal cord compression, what type of cancer they have, the extent of their metastatic disease, and also their current performance status. So I just thought this was a really interesting, and it's a bit dated, but it's an interesting chart of survival data. So we certainly can see that in lung cancer, a patient diagnosed with a spinal cord compression, prognostically, this is not a great predictor of survival. But in the case of something like myeloma, you can see why that early intervention might be really important, because intervening early might mean that we keep the patient walking for that extra year of life post spinal cord compression versus in a wheelchair. So in summary, the malignant spinal cord compression is a palliative care emergency. Again, our cardinal symptoms are going to be back pain in people that we know have cancer. And we hope to identify it early so that it doesn't trickle down into the cascade that we talked about, including paraplegia. Early recognition of these features can offer more hope in terms of improving outcomes for these patients. And again, early treatment will improve the outcome. Okay, so that's my quick blitz on spinal cord compression.
Does anybody have any questions or comments about spinal cord compression before we go on?
I just had a question, if I could,
Yeah.
and it might be something that everybody knows and I don't. But when you refer to systemic chemotherapy as a ways to intervene, I don't have a lot of knowledge when it comes to that. How does it differ from just the regular chemotherapy that we run into?
Yeah, it's the same. It's the same thing.
Oh, okay.
Any chemotherapy that's injected essentially parenterally would be considered systemic. There may be certain specialized chemos like a HIPEC or something like that that might be more geared towards localized treatment with chemotherapy, but no, you got it. It's the same thing as chemo.
And how, like, what role would that play in terms of the spinal cord compression? Like, it obviously comes into play to relieve some of the pressure, but Do you know how, like how that would actually work?
So the idea would be that that chemotherapy is attacking the tumor that is
Okay, directly.
pressing against the cord. So
Okay,
if the
okay,
chemo is successful in shrinking that tumor, it's just going to take some
okay,
pressure off of the cord.
okay,
Um,
okay,
yeah,
okay.
for control. I mean, certainly we would be hopeful if that tumor was responsive, that other tumors that may
Mm,
be present would be
yeah,
responsive as
exactly.
well. Yeah.
Okay. All right. Thank you so much. I appreciate
Oh,
that.
you're welcome. You're welcome. Thanks for your question.
I was just wondering, Melanie, for somebody who's more in an end of life trajectory, like the MRI, the going to the hospital for radiation would be quite a production, I would imagine.
Yeah.
I guess that's quite a conversation you'd have to have with people, right?
Yeah, and I think it really speaks to the value of some goals of care conversations in there and really where that patient is at in their trajectory. Definitely palliative care applies to people whether they're at a PPS of 80% or 10%, but how we might approach the all of these palliative emergencies really might differ, whether a patient's a 60, 70, 50, 40 versus that 30, 20, 10. So a good open goals of care discussion. If my patient already isn't getting out of bed, more likely than not, we're taking more of a purely comfort focused approach. And I wouldn't necessarily be looking to reverse the spinal cord compression because at the very best scenario, they're still going to be in bed, right? Because their PPS is so low and they will have used an awful lot of energy and resources and maybe precious time in the hospital, right? So certainly for those patients, I might be looking more strictly at managing their pain, making sure that we're able to care for them in a dignified way in bed, managing pain with turning, bowel care, things like that. Thanks, Val. I'll move on to our bowel obstruction. I will say, like, each of these topics I could probably talk for 2 hours on. So this is just an overview, and certainly if anybody had questions, I'm happy to take emails and whatnot. I'm just going to minimize you guys and move on to my bowel obstruction. So bowel obstructions can be partial, meaning that a small area of the lumen still remains open, lumen of the bowel, or it can be a complete obstruction, and they can happen in the small intestine or the large intestine. Mechanical obstructions arise from within the intestine, so it could be a tumor that's growing on the inside or growing in the inside around the lumen, like an apple core. But it can also happen if a tumor or giant lymph nodes outside of the intestine are pressing, right, and compressing that way, similar to how we just saw the spinal cord being compressed. If the bowel gets compressed too much, we lose patency and we have an obstruction. And then we can sometimes get what's called a functional obstruction, and that can be from things like a paralytic ileus or nerve damage, where it's not necessarily the lumen that's closed, it's just the electricity and the innervation of that bowel just isn't working to move stool through. So we can have, can you guys see my mouse when I move it around?
Yep.
Okay.
Yep. We can see
So
it.
so at the top of the small intestine here, where the bottom of the stomach dumps in, we can get what's called a gastric outlet obstruction. So this would be a very proximal bowel obstruction. We can get obstructions anywhere along this mess of small bowel. We have the large colon starting here, and again, not uncommon to see obstruction anywhere along this bowel. So gastric outlet, we typically will see in things like pancreatic cancers. The pancreas would sort of be right over in this area. And if there's a giant tumor pressing, we see it press into the stomach to block that gastric outlet. We can also get any obstruction through here. So liver, gastric, gallbladder, everything that's up in this area presses on the stomach to cause that gastric outlet obstruction. I'm just going to pop all these in here. In the case of the small bowel, again, things like the liver pressing, the pancreas that would press, the gallbladder that could press anywhere along this small bowel here. We often will see colorectal cancer, peritoneal cancers, and ovarian cancers causing small bowel obstruction as well. In the distal bowel, so down low, this is where we typically will see rectal tumors obstructing. And anywhere along here, you have your colorectal cancers, ovarian, appendiceal cancers, and your peritoneal cancers. The peritoneum is like the lining that goes between your stomach and the muscles and all that jazz. And when tumors pop up in there, they press and put pressure on the bowel to collapse it. So with a gastric outlet obstruction, if you remember, that's high up where the stomach empties into the small bowel. Some of our early signs are that the patient's just not going to be able to eat very much. And the reason they can't eat very much is because food doesn't empty very quickly. So they get a very early filling or an early satiety. They feel full from eating just a few bites. We often will see rapid onset of nausea and cramping, and usually they will vomit up what they've put into their stomach, and certainly in a complete obstruction, the body's really smart and is good at getting rid of food in a way that is easiest, so often coming back up than trying to push against an obstruction. Vomiting will often relieve the nausea and pain, and the bowels will continue to empty after the obstruction because the obstruction's up here and we have a whole whack of bowels that needs to empty out before we clue in that the bowel movements will cease. So it's, although it's a bowel obstruction and we typically think about people not pooping, when the bowel obstruction is high up, the poop that's already in there still is going to empty. So it can take us a little bit of time to clue in that there's something going on. In terms of small bowel obstruction, again, you're going to have that pain, that nausea, the vomiting. And again, because it's closer up to the stomach, it's going to be way more pronounced after eating. And again, because you have that large bowel that still needs to empty out, it will continue to empty after the obstruction takes place. And in the case of large bowel obstruction, we have a lot of tubing up top that needs to fill up before we get those nausea and vomiting cases. But what you will get is some abdominal distension, you'll get some cramping, and you'll often notice that bowel movements cease before the patient becomes nauseated necessarily. Unfortunately, in all of these cases of large bowel obstruction, if we don't manage them well, eventually the contents of the stomach do back up and we may get feculent vomiting, which is essentially vomiting stool type material, which is very, very distressing. So for all of these, we're going to see pain for sure. We know that putting things in is a no-no because it's either going to cause a lot of pain, nausea, and be vomited up, or it's going to work its way down, but then get stuck down there to compound up, right? So we make these people NPO. We say stop eating, stop drinking, let's rest things until we know what we're working with here. We always want to have a strategy to address things like pain and nausea using the subcutaneous route, because again, we don't want them necessarily taking things by mouth. We want to have PRN dosing available to them. Sometimes we use medications like antispasmodics, like Buscopan, if there's a lot of cramping and vomiting involved. Octreotide is also really good for patients who are vomiting quite a bit, particularly in these high up obstructions. And sometimes there is a role for parectal suppositories. So we do want to try, if we can, to empty the bowel, And if administering some suppositories or laxatives will help, the parectal route is often our best course of action there. Again, with nausea and vomiting, we're just going to try and minimize what's going in. We often use Haldol sub-Q as our first line in these cases. It's quite good for that mechanical kind of nausea. Buscopan, the octreotide again, which just really slows down gastric secretions. If they were in an acute care setting, often NG tubes will be used. And what that does is it just takes out the fluid that's in the stomach, right? So that it's not causing all the nausea and it's not going down further. In the community, we do not put in NG tubes. And the important thing is often metoclopramide is a medication we use for our palliative population. And in this case, we would want to stop it. Metoclopramide is a promotility agent. So if we're encouraging the stomach to empty, but it's emptying against an obstruction, often will increase the person's pain and vomiting if we continue to use it. So we stop that medication. So with bowel obstructions, we do try and attempt to manage, and depending on where the client is in their trajectory, management might just look at pain control or symptom control, stopping the nausea and vomiting, but not necessarily opening up the bowels so that their bowels are moving. In a case of a person who's a PPS of like 60 to 30, again, my goal is always to try and open them up a little bit to keep the bowels moving, or else without more invasive intervention, they won't live, right? If they can't eat, they certainly can't live. So again, if I get that call from the nurse, the first thing I'm going to try and do is start some of that steroid again. The dexamethasone works really well to decrease swelling around the tumor when we assume that it's a tumor causing the obstruction. So even if we can just open up that bowel a little bit to squeak some fluids through, we're going to really relieve some nausea and hopefully some pain and start getting some bowel movements going again. Some other interventions that can be used for people who are eligible or sort of in that earlier trajectory would be something like stenting. So using a colonoscopy, they sometimes will go up and open up that bowel against the tumor that's there so that it's more patent. In some cases, a PEG tube can be inserted. So basically the tube goes into the stomach. The patient can eat, but then open up the PEG tube to drain out what they've put in their mouth. And this is more of a comfort thing for patients who feel hungry or really want to taste and chew and eat. They don't get a lot of nutrition out of that because certainly they're venting it before it gets into the small intestine. But for someone who's doing something like TPN, this may be a really good option for quality of life. An NG tube, again, this would be in a more acute care setting because we don't insert NG tubes in the community. And then again, hydration, because we're telling these patients, nope, you're not going to put anything in, and they may get quite thirsty or weary very quickly with no intake. And again, depending on goals of care, hydration may well align with that. So in terms of bowel obstruction, we sort of know where we might be anticipating one. Certainly patients with colorectal cancers who haven't had surgery would be high risk. Our ovarian cancers are quite high risk, liver and pancreatic as well. So I always say, let's prepare for the possible. And what that might mean is having that symptom response kit in the home earlier. We might include something like dexamethasone or octreotide in that kit, so it's already available in the home should these symptoms arise. And then again, this good goals of care discussion. What would the patient hope for if this event were to occur, right? And again, that's a hard discussions aren't a hard and fast rule. They don't take place necessarily in one visit. They're built up over time and they ebb and flow. So our underlying goals will always guide the intervention, and then just really hashing it out with family in terms of what good decision making looks like, family and patient, of course. So looking at what the potential complications would be if we weren't to intervene, what things might look like if we did intervene, and what all of the options are. Oh, that's bowel obstruction in a nutshell. Does anybody have any questions?
No, not me. Thank you so much.
No worries. This is like a quick blitz. What's my time? It's 2:08. Okay, we're good. We're in good track here. It's okay if I go on to bleeding? Okay. I'm gonna minimize that. So catastrophic bleeding, I put this one in because although it doesn't happen very often, when it does, it's bad, right? So again, it is a rare complication. There's like a statistic out there, like 5% of the population or the oncology population are at risk of a catastrophic bleed. And of those, sort of this 3 to 12% range will in fact bleed. I've been nursing palliative care for 22 years and I've had it happen twice. So it's fairly rare. A major arterial bleed, like you can see there, that this is terminal in nature. But we also will get some smaller bleeds or some bleeding that aren't necessarily terminal in the event itself, but will precipitate death. In most of these cases, when we're talking about the oncology population, this is because bleeding happens because tumor essentially has eroded a major blood vessel. And then in the case of smaller bleeds, it's really just that tumors have sort of wrecked the system there. We see that with like colorectal tumors that are slow bleeding. Sometimes things like lung cancers or where the bronchi are involved, we'll see hemoptysis over time. Wounds can be another one that just ooze and bleed because tumors are so vascular. So we really, really want to identify early patients who might be at risk. So if you have a patient with a really large mass on their neck or a malignant wound, that would be something that I would probably talk about bleeding with and want to prepare. Esophageal cancers have a propensity for bleeding. Tracheal and lung cancers, rectal and GI, and some gynae cancers, of course, too. Sometimes we will get a little warning. So a patient who's having like recurrent hemoptysis, having recurrent blood in their stools, who have like a mass that's sort of just bounding, those are people that are giving us a little warning, right? And those would also be people that I would make sure I have a plan in place for a catastrophic bleed, even if it were never to happen. We want that planning to take place. So again, we're going to prepare for the possible. And this in the community, we often prepare by having medications available in our symptom response kit. So we want to make sure we have sedating doses of medications. And in patients who are giving us a little bit of warning with that, say hemoptysis, for example, often we will have it pre-drawn and doing some teaching with family members well in advance. So in terms of sedating doses, we're always using midazolam essentially. And generally speaking, a starting dose would be about 5 milligrams, and you would administer once, but then they could repeat that every 5 minutes or so. I usually keep 3 pre-drawn doses up. And the goal of the medication is to sedate, right? So we want the patient hopefully sort of be in a nice drifty spot. If they exsanguinate, we know that we've given them medications. We also try and keep like a little kit together, and often I'll stash this or ask the family to stash it just under the hospital bed if they have a hospital bed, or at the bedside. So often in that kit, I usually just use a tote, like a Rubbermaid or a laundry basket, and I want it filled with dark towels. So if a person starts to bleed, you get that dark towel underneath them, and it can really minimize the appearance of blood. And that's for the patient, but that's also for the family. I'll often encourage dark colored sheets, dark colored duvet, dark pillowcase. And again, it's really just to minimize the appearance of bleeding should it happen. In that kit, I often encourage the family and the nurses to have like a call list. So on it, it's going to be Bayshore, the 24-hour number, for example, RPCT, my daughter who's going to come over and help me. Just having that call list so they're not flipping through the chart in the home. They know exactly who to call. And then a plan for afterwards. In retirement home setting, this might be a little bit different, but certainly having that kit available for the staff at the retirement home, it might have our PCT number if we're involved, the physician's number if they're like, so that we can reach somebody very quickly, the visit nurse, so we can reach somebody quickly. If a person is bleeding, and it's a catastrophic bleed, it's minutes for this person. So we always want to just stay with the patient. We don't want to run out and try and find someone to call. We have the kid underneath the bed and we stay with them. But having again that plan for afterwards, because the cleanup is quite something, and where care providers will need some support. So preparation of patients and caregivers, I often will talk to patients and caregivers about this possibility. I might just start by asking, how much would you like to know? I'll use a wish, worry, wonder sometimes, and I always use wish, worry, wonder just because I think it's such a great tool, because it is a really difficult conversation where we're towing the line between really scaring people but also being really prepared and empowering, right? So in a wish, worry, wonder, you start off by saying, I wish. So I wish I could tell you that your tumor will not cause any further symptoms, but I worry that with its location, you might be at higher risk for complications. I wonder if we can make a plan to be sure we're prepared for everything. And that's how I would use wish, worry, wonder to open up a conversation about it. In the case of like slow bleeds, we might have some options in terms of using some medication. So we can get tranexamic acid. It comes in a tablet, but if I have someone who has regular hemoptysis, this is definitely something I offer. The downside to tranexamic acid is it's not covered by ODB and can be expensive. We can use tamponade. So if somebody has like these chronic nosebleeds that can get out of control, we can use tamponade like a clip, right? Wounds might respond to tamponade, things like vaginal bleeding as well. Cautery might be an option. We often see this for like small little bleeders and wounds. Sulcrate can be effective for some small bleeds in malignant wounds in particular. Radiotherapy, so radiation. If we have a tumor that's causing a lot of problems and bleeding, targeting that tumor for radiation and maybe just one zap, like a palliative radiation, may be enough to stop the bleeding. We see this a lot with hematuria, so radiating the bladder, or the kidneys can be very helpful. With rectal tumors, it can be very effective as well. And sometimes in the case of hemoptysis, if we're focusing on tumors in this region here, we can often be effective in decreasing that bleeding. And in some cases, I've had patients do ablations or embolizations where, and again, this is an advanced procedure. It takes place in the hospital, but basically they're going to cauterize an artery so that the blood flow to from the tumor is essentially stopped, and then the bleeding stops. So in the case of palliative emergencies, can we always fix the underlying cause? No, not always, but sometimes. Can we always focus on managing symptoms and things that come up? Yes, because that's good palliative care. So emergent syndrome management sometimes, emergent symptom management always. And I think that's it. Does anybody have any questions? I'm going to stop my sharing.
Yeah, thank you so much. I can tell you've been doing this for a while. I'm actually curious,
Mhm.
when you were talking about the midazolam to sedate someone who's
Yeah.
in that state, you refer to the patient like 5 milligrams for a naive
Mhm.
patient and then tell them for a non-naive. Do you mean someone who's responding to 5 milligrams? Is that what that term means?
Yeah, that's a really great question. Thank you. So naive would refer to somebody who's not used to these medications. So if
Oh,
it's
in
the
that
first time
sense.
this patient has
Okay.
ever had midazolam, I would probably go with a lower dose. If
Okay.
I had a patient that has been using midazolam for the last 2 years to help manage
Mhm.
symptoms, or is on a lot of Ativan or
Okay.
clonazepam, lots of opioids, things like that, they may
Okay.
be a little less sensitive and need some higher
Okay.
dosing.
Oh, okay. I just wasn't sure about that terminology, but
Yeah.
thank you for explaining.
Yeah, no problem. 5 milligrams will probably be enough to do anybody, honestly. And
Okay.
what I will say, truly, is when they bleed real quick. And I'm not
Mhm.
even sure the circulatory system has enough time to deliver. Where I
That's
think
true, right?
it's powerful for, especially if we're talking family, where it's powerful that they're prepared and have something to do is the act of doing something, right?
Right.
Like they go on
Right.
autopilot. Um,
Yeah.
but I'm not certain in a catastrophic bleed that we may get sedation in time. I'm not sure. The one case it's so interesting. I mentioned I've only had this happen twice in 22 years, and
Mhm.
I'm touching wood as we speak.
I can
But
just
oh, and my
imagine.
dog thinks someone's at the door. Um, it happened within 24 hours of each other, two patients within
Oh my
24 hours,
gosh.
and two
Wow.
very different scenarios. One was a woman who had a tracheal cancer, and she was giving us warning. She had hemoptysis, even with tranexamic acid. But when she literally was eating dinner, she coughed and she blew. Like, and it was so quick. The spouse was there. We had everything ready. We had the kit. But I suspect she exsanguinated so quickly. Like he
Oh,
gave her
wow.
a dose and like it was amazing. He did so well.
Mhm.
But the nurses, when the nurses came, they just said the volume of blood
Mhm.
was unlike anything they'd ever
Right.
seen. And in the other case, unfortunately, we weren't really prepared. Like his PPS was super high. He was still under active treatment, but he was an esophageal. No warning, no anything. He'd had friends
Wow.
over for dinner. They were getting ready for bed and he vomited and just
Oh my
massive
God.
hemoptysis. Yeah, yeah.
Wow.
So two super different scenarios. One we were prepared and one we weren't,
Yeah.
unfortunately.
Wow.
Yeah.
Do what you can, right?
Yeah, totally. And like honestly, like with our team, we've had other bleeds, like for sure, and often 911 gets called, but
Hmm.
when the paramedics arrive, it's often um it's just a knee-jerk reaction, and it's not the wrong reaction to call
No,
911.
yeah.
Like, it's really not.
Yeah.
They just can't get there in time.
Mhm.
But they're there to help support afterwards. And then often
Yeah.
they'll call our team or the visit nurses.
Yeah. That's
It's
great. Well,
brutal.
thank you
It's
so
really
much.
brutal.
I really
Yeah.
appreciate all that knowledge. My goodness.
Yeah, no worries. Anytime. Miranda?
Hi, and I don't know whether it's a stupid question, but I just think it seems like a constipation is quite common for seniors, right?
Mhm.
And then usually it's like, do they have show any symptoms that they have bowel obstruction? And will bowel obstruction will have other like a delirium or delusion symptoms that we can tell?
Yeah, constipation is a huge cause of delirium, I find anyways. The difference would be, so yes, you're right. As we get older, like bowel function definitely slows down, even in the absence of a disease, right? Even just the process of getting older and frailty, we eat a little bit less, motility time is different, we are less active. So there's lots of things contributing to that constipation. Constipation is a problem, right? So if your loved one or your patient or you're identifying a resident in your home who hasn't had a bowel movement and you're getting on 3, 4, 5 days, they're going to become symptomatic. And so it's important to first identify the absence of the bowel movement and then look at other associated symptoms. If that patient's having a lot of pain, if they're starting to be nauseated and vomiting, I would be very suspicious. The source of the obstruction may just be the constipation itself. So it's called obstipation, right? They're full and it's hard. And they're going to need a lot of laxatives, some enemas probably to help break up that constipated stool to get them moving again. But if they have a previous history of something like a colorectal cancer or an ovarian cancer, I might be a little bit more suspicious about a bowel obstruction. Yeah, yeah,
Thank you so much.
yeah, you're welcome.
Melanie, I want to go back to the bleeds.
Yeah.
I'm trying to think, you know, for some patients, depending on the type of cancer, they may have tumor kind of around large vessels. And I'm wondering if those tumors like went through the vessel wall, but they would bleed internally, right? Not, it wouldn't come out. I'm just trying to.
No, yeah, you're right. Yeah, you're right.
So it would be pain, I think, would be the big symptom, and then they would likely pass out, right?
Yeah.
Yeah.
Yes, and like if you think about something like the presentation of an aneurysm, right? Like an abdominal aneurysm, it's often acute onset of pain, feeling really unwell, knowing something's not right, like that sense of doom. And then without intervention, it's a fairly quick demise potentially. So I imagine it would be something like that.
Okay.
Yeah.
Well, this has been a great session. Small but mighty crew, and we're all really grateful to you, Melanie, for your incredible expertise and
Thank
clinical
you.
acumen. It's great to know that you're out there and able to help.
Yeah, anytime. Happy to do it.
Anyway, thanks everybody for coming.
Thank you. Really
Thanks,
appreciate it.
everybody.
Thank you.
Thank you.
It's a good
Bye-bye.
session. Bye-bye.
Take care.